will ask us to, hi. All right, welcome to to Remaking Medicine. I am Emily Peters. I'm here to talk about change and culture change and how we address big issues in our healthcare system. And it's early in the morning on Monday morning, but I am so thrilled to be here and to be with you guys early in the morning out here in foggy San Francisco, because we have Dr. Luke Messick here, who wrote this book that I am now obsessed with and that I think everybody should read, called Your Money or Your Life, which is debt collection in American medicine, very aligned with the topic of the book that I'm researching right now. And like I said, just my favorite read of the summer. So welcome, Dr. Luke Messick.
Thanks so much. I've never heard it called a summer read before, but
it's a summer read for a very particular kind of nerd.
Yeah, so nice to be here. Thanks.
Yeah, so give us the introduction quickly to where you are working, your current role, and then I want to get into how you decided to write this book, because I think it's a really fascinating journey.
Yeah, I'm here in Massachusetts. I work as an instructor of emergency medicine at Harvard Medical School, and I'm an historian as well, and I work as an attending physician at Brigham and Women's Hospital in Boston. Yeah, that's me.
Yeah. And so you were here, succeeding in medicine, doing the good work, helping people who are in their lowest moments coming into the emergency department. And you started to have some questions, right? And so tell us how you started to think about medical debt, medical collections, and kind of walk us through how you got to this point where then you wrote the book about medical debt.
Yeah, absolutely. I didn't think I was going to write about this. I never planned to write about this subject until it kind of smacked me in the face. I was a resident in Rhode Island. You do residency training in emergency medicine for 4 years. You basically live at the hospital, which is why they call it residency, and spend a lot of time learning the craft and spending time with patients. And I noticed that really often a patient or their family member would ask me how much something would cost, or an x-ray, an overnight stay in the hospital. And I didn't have a great answer for them. I mean, almost no doctors do, because it really depends. What's your insurance? What's the negotiated rate? How, what exactly are you ordering? And so, as much as people have tried to tout the virtues of price transparency, it's still really hard, if not impossible, to tell patients exactly how much their emergency department stay or overnight hospital stay or CT scan or x-ray is going to cost. So I couldn't really answer it for them. And I noticed that they would sometimes, express a lot of worry, and sometimes they would straight up not do it. They would leave the hospital. And, sometimes it was really tragic. People would come in with late stage cancer or with really tragic diagnoses that could have been detected earlier or treated earlier for want of money. They would tell you straight up, I didn't have the money for it. I didn't want to burden my family with the debt. And so I used to try to counsel patients, don't worry about it so much. The hospital will work with you. We have financial assistance like every other nonprofit hospital, and you don't really have to worry about that now. You should focus on just getting better and following our recommendations if you can. And then I realized that in some places, at least, that wasn't true. That some of my friends at other hospitals around the country were starting to make some noise about the debt collection practices of their own hospitals. Johns Hopkins, there was a real movement afoot about hospital lawsuits against low-income patients. Sometimes their own employees, like janitors working at the hospital, were getting sued because they couldn't afford their hospital bills. And I thought, wow, that's nuts. That's crazy. That a nonprofit hospital is going to sue low-income patients when they can't afford their bills, and then garnish their wages and put liens on their homes and foreclose on their homes and seek arrest warrants. That can't happen. And so I said, you know what, let me just make sure that my own hospital isn't doing this. So I went down to my county courthouse, which I'd never visited before, but actually a pretty beautiful building. I somehow more garlands than my own hospital. And so I looked into it, and I looked at the court records, and I found that actually my hospital was suing patients by the hundreds every year through a third-party debt collector. These were not people who could afford the bills that they were being sent for thousands of dollars. They were, people living on disability, single working moms, recent immigrants. And I was just I was floored. I was ashamed, to be honest, that
Mhm.
I was a part of this system and that I had been misleading my patients. Not knowingly, but still misleading my patients into, something that sounded comforting to me, but was not at all what
Mhm.
was going to happen to them.
Mhm.
And so I didn't really know what to do at that point. I ended up writing a short piece about it in a local progressive blog that I thought no one would read, and then got a call the day it was published from some higher ups in the hospital saying, "We got to talk." And I was nervous, because you're a resident, you're kind of in this limbo stage where if you complete the residency, then you're golden.
Yeah.
The rest of your life is basically yours. But if you don't, then you're ruined. And so I didn't know what was going to happen to me, but I was confident that I had my facts right. If
Mhm.
history PhDs teach you anything, it's to get your facts right. And so I I wrote this piece and I spoke to the hospital administrators and I told them, this is what's going on. They said, "No, it's not. We're not suing patients." And I said, "I have the records. I can show you the exact court
Mhm.
case numbers. You are suing patients. You sued some last week."
Mhm.
And eventually they got back to me and said, "Oh, we didn't know about this. The CFO of the hospital didn't know about this, but we're going to change it." And I was
Mhm.
grateful to hear that, but just super confused. Like, what's the deal? How is it possible that the CFO of a
Mhm.
hospital doesn't know that they're suing patients? And so that triggered my interest and got me into this. And um, I had to figure out how it came to pass that we
Yeah.
are doing this to patients, and that the doctors and even the financial executives at the hospital don't even know about it.
Yes. And I think with your historian perspective, really interestingly, you talk about this as a problem that is accelerating right now, but also that this is an old problem with medicine, right? Of how we talk about or don't talk about how we pay for healthcare, right? And this goes way, way back. Do you have a
Yeah.
favorite anecdote of kind of how we've emerged on this path?
Yeah, for sure. I mean, it's a long history. I won't get into all of it here, but I think it's important to remember that there was a time when doctors were responsible for collecting their own
Mhm.
payments from their patients. And I'm not going to say that was a better time.
Yeah.
It was a time when these were still really fraught conversations,
Yeah.
but it was part of the therapeutic relationship that was unavoidable. And
Mhm.
so a doctor would have to decide whether their patient could or would pay. They didn't really have a good system for doing this. I mean, doctors would write about how, oh, you got to look at how they're dressing, but maybe they'll dress really shabbily just to try to get one
To
over on
trick
you.
you. Yeah.
And but a doctor would decide, are you going to, if they said they couldn't pay, are you going to forgive the debt? Are you
Yeah.
going to lower the bill? Are you going to make some sort of payment plan? Are you going to accept in-kind payments? Are they going to pay you in chickens or pies? Are you going to sever the relationship? Are you going to take them to court? And I don't think that was some halcyon bygone era, but I do think that having physicians fully aware of the fact that some of their patients could not pay and have them be the decision makers could be more humane at times than, you know,
Mm.
hiring some third party debt collector uh, that really had no clinical relationship with the patient at all and just saw patients as Excel spreadsheets and numbers to be
Mm.
collected,
Mhm.
paper to be, bought and sold on secondary markets. And so that transition from that, personal relationship to the completely disembodied financialized relationship, I think has been one that has
Yeah.
been really harmful for patients and even for physicians because we don't know what's going on.
Yeah. I recently learned of the term emotional epidemiology, right? And thinking about public health in terms of the emotional connections and why people act in these different ways, which is very, very different than the scientific epidemiology of, having a vaccine that's effective and everyone should get the vaccine. And, really approaching it from an emotional perspective, I think you can see why we built a healthcare system where the physicians and nurses and even hospital leaders are very shielded from the cost piece. From an emotional perspective, that's a really difficult conversation. You don't want to have that conversation with your patients, right?
Yeah. Yeah, no, that's a great term. I never heard it before. And
Mm.
to be frank, I don't want to talk to my patients about their bills when they come in with a heart
Yeah.
attack. I think that's the
Yeah.
last thing they should be worrying about. In my mind, charging patients at the point of care for their healthcare is just always a losing proposition. And we have
Mm-hmm.
reams of data to prove that, not only in, every other country that has found a way to provide healthcare
Mm-hmm.
without significant charges at the point of care, but from our own.
Mm-hmm.
And so but I think as long as we have the system we have, then physicians, nurses, PAs, techs, like everyone who's involved in, on the ground frontline healthcare should know what our patients are facing, so that we can help them face it as well as they can.
Yeah. I mean, I think there's a huge element here when we talk about distrust, medical misinformation, disinformation. If you go into the hospital and you're with a wonderful physician and they're trying to help you and they're saying, I'm being very honest and truthful and you should help me, you should listen to me. And the patient says, what is this going to cost? Am I going to go bankrupt because of this? And, we're not able to have that conversation with patients in an honest and truthful way, right? Most of the time.
Yeah.
And you can see how that really factors into people just being, the whole system is full of liars and cheats.
Yeah. I mean, that's the thing, right? Like, I've had patients say, you're just trying to make a buck off me. And if I was a resident and telling them, I make $60,000 a year and it doesn't make a lick of difference whether I order this test or not for my pay, that they don't care. Then, like, the whole system seems out to get them. And can you blame them? Like, the number of middlemen in healthcare just literally making a buck off human suffering without offering much more in the way of actual patient outcomes or actively, detrimental to them, like that. How can you blame them for laying that blame at the feet of the only person in that system that they see?
Yeah.
So, we have a choice. Either we can take up their side and say, listen, you're totally right. This system is out to get you. And I'm here to try to help you navigate your way through it and fight for a better one. Or we can stay silent or
shame
or
profit, is a very powerful emotion, right?
Yeah.
Shame. I was telling you just when we were joining the call that, when I talk to physicians often about the fact I'm working on a book about money and medicine, they feel, you can just sense that shame just washes through. And a lot of people are not even able to have that conversation. It's so painful for, I think, a lot of physicians, and especially when we're talking about things like oncology, right? Which, like, very life-saving, very, very expensive, very likely to bankrupt patient, right? But at the same time, here I am, I'm a lifesaver, right? I'm curing cancer. I'm this hero. That emotional field between the shame and the heroism there is just extremely potent. And I think I love books like yours because history and facts and data can help us look at things in a way that's maybe not as shameful, right? And to fight the long defeat. I want to bring up Dr. Farmer because you are part of a very select group of people who got to work with him, and how that maybe, that experience of working with him helped you think about how you go in eyes open and curious and maybe not hopeless into conversations like this.
Yeah. No, I mean, Dr. Farmer was a tremendous part of my life, and for so many others. I mean, you've written about some of them in Artists Remaking Medicine, your last book, which I would super recommend. You guys have to read it. Even if you don't know you have to read it, you have to read it. You write a chapter about Michael Murphy and the Mass Design Group, which is a group of architects who helped design some of the most beautiful buildings I've ever seen in my life, which is not something you almost ever say about hospitals. I mean, the hospital in Butaro, Rwanda, operated in partnership by the Rwandan government and Partners in Health, the organization that Dr. Farmer co-founded, is like just the most beautiful building to walk through and care for patients in. And it's just breathtaking. If you ever find yourself out there, you just have to visit it. And their philosophy was something that you almost never hear in medicine anymore, but I think harkens back to some of our founding ethos. I mean, hospitals, what are they? They were born of almshouses. They were born of places for the poor when they had nowhere else to go. And Farmer talked about a preferential option for the poor, which is an idea from liberation theology, which sounds a little complex, but it's not. I mean, it's just saying that, like, if everyone needs our help, which they do, then the poor need it even more. And so we should be focusing on their care as much, if not more, than than others, which is not something that most of our healthcare system can
Yeah.
claim to have done. I mean, we basically have a triage system by wealth in this country.
Yeah.
Everyone talks about waiting lists and rationing care. Well, we ration care right now, just not in a rational way,
Yeah.
by any standard of medical need.
And an interesting part of that hospital too is that they built in jobs for local people in the creation of that hospital, so that people not only had a financial benefit of the development of that hospital, but that they felt very invested personally. And like, I helped make that wall, right? Or I helped tear down that courtyard, and like, I have a personal relationship. And so that's a piece where I think the cracks in the wall start to show through, right? Of like, oh, you can create a beautiful hospital for the poor. And in the process of doing that, you can also create jobs, and you can also create financial opportunities, and you can create systems in that community that, are sustaining. And there's a way out of that, right? Potentially, that's really beautiful. And so if you don't push the money down, don't, push it away. If you think about it as part of that system, that money in medicine has always been there, right?
Yeah.
That very, very infrequently has there been a healthcare system truly invested by just solely charity, I would say, potentially, historically, right? I mean, there's a few religious moments of the poverty in the almshouses, but, doctors need to get paid, right? Everybody needs to get paid. Everybody needs to find a way to make this sustainable. So I want to pull up a question that somebody asked in the comments. And so this is maybe, excuse me, the piece that always comes up when people talk about money in healthcare, and this idea of like, well, we should just immediately switch to single payer. Single payer would fix this. Why do you think, I think you're a proponent of, yes, single payer would be a good movement forward. Why don't we make that switch? What is it about American history, American culture, potentially, that prohibits us from doing that? And how can we think about that maybe in a different way? Huge question.
Yeah, no, of course. I mean, single payer is a very rational solution to this problem. And single payer being, instead of having everyone pay for-profit health insurance companies to cover some of the cost of their care, why don't you just use tax revenues in the way that Medicare does to pay healthcare providers for that care, right? A single payer instead of multiple payers, many of them seeking profits of their own, and earning a profit from saying no when someone needs care. So that is, I mean, Canada does that. The UK actually has like a different method of care where it's not necessarily single payer, but all the healthcare providers and most of the healthcare providers and hospitals are government institutions. Like that's an even more, socialistic, honestly, answer to this problem. Single payer is kind of a moderate solution in the scheme of things, even though it sounds like a lefty out there solution in the United States.
Yeah.
And what does it mean? Like if you gave Medicare for all or Medicaid for all to everyone in this country, then you'd have much lower out-of-pocket payments that patients would have to face. You'd have fewer middlemen in the process taking their piece of the pie, and so the overall cost would be lower. And instead of paying, you're paying a huge portion of your paycheck to the private for-profit health insurance company, you'd instead pay a smaller portion in payroll taxes and get probably better care as a result if it was well structured. Now, sounds great, but what would it take to get there? Like a lot. We've tried it so many times. I mean, it was up for debate when the New Deal was being discussed in the 30s. It was up for debate again in the 40s under Truman. It was up for debate again in the 60s. It was up for debate again, in some of the Clinton discussions. And then, there was shreds of it left by 2008 and 2009 when we talked about the ACA. And every time there are these huge, massive interest groups arguing against it. Initially, it's physicians. The AMA in the 40s and 60s was like a huge opponent of single payer. They even hired Ronald Reagan before he was president to give these little rah-rah speeches that people would put on their LPs in their rooms and talk about how, if we pass this, they was talking about Medicare. If we pass this, our children and our children's children we'll have to tell them one day we lived in an America where men were free. Like that was the horror story we were telling about Medicare.
Yeah.
When Ronald Reagan was speaking for the AMA. And so there's all these scare tactics, in the 90s. By that point, the health insurance companies were hugely powerful. The drug companies were hugely powerful. Same thing in the ACA era. And so what you face is just these massive entrenched interest groups. And, I think in 2010, when the ACA was being discussed and there was talk about a public option, right? Like you could buy into Medicare essentially, even if you weren't 65. There was a huge move against that. And even Obama was like, it would be much more rational to have a single payer healthcare system. But, look at all the people who work for health insurance companies. There's millions of them. What would they do? And so like my answer to that is similar to the answer a lot of people give, which is that like those people have tremendous skills, but instead of asking them to say no and figure out how to deny people the care they need, like task them with helping people get the care they need instead. And so we could repurpose our healthcare system in any number of ways. And some places we can talk about it have found ways to do that in small and meaningful ways, but we still have a system where like too many people profit off of the system we have.
Yeah. I mean, that our healthcare system is a spectacular jobs program, right? Yeah. I mean, completely sustaining our economy in many ways, replacing all the manufacturing jobs, in general, like a pretty good place to work for most people. Not always the best, but decent, right? Good wages. Yeah. And I think that's where a lot of the hesitation does come through of like, how do we disrupt this machine that we've created, which is this massive jobs program? And it is very unfair, but there's sort of this idea of, it does, there are people who get giant boats because they work in this system, but there's also a lot of people who pay their mortgage, and that's also the thing. So, and I know that we've tried, Vermont, for example, tried a single payer approach. I think it's just interesting to think about from a historical perspective why those things haven't worked and what's specifically so American about our system, right? But there's a great book called Unrest. I have to think of what it's called, but it's about political transformations. And one of the components that's looking at these historical transformations is that there needs to be first a really honest reckoning about what is happening. And I don't know that we're there yet in medicine. I don't think that most people, even though terms have emerged around financial toxicity and, the medical debt, and you're able to write this book and have these conversations, in general, it doesn't feel like we're not necessarily there yet in terms of thinking about, we have a huge issue with the cost of medical care in the United States. I mean, would you say maybe we're further on the tipping point than I'm assuming here?
Yeah, I mean, there's more attention to medical debt today than certainly there has been at certain points in the past, but it kind of goes in cyclical movements. I mean, I write about in the 80s when, there were stories in the Washington Post about, like a baby who got AIDS from a blood transfusion in the hospital, and the doctors didn't tell the parents because they didn't think it was appropriate, but then the baby died and the parents got a massive bill for the baby's care, even though the hospital had been the place where he'd contracted the disease, and they couldn't even pay for a headstone. It was like the most tragic, awful stuff that made the headlines, but didn't end up changing changing policy nearly as much as you would think. And in the 2000s, you have a series in the Wall Street Journal, a great expose about, elderly people in Yale New Haven whose homes are being foreclosed on by Yale New Haven Hospital and hospitals around the country. And that leads to some voluntary moves by healthcare providers after some, hints that there might be legislation in the offing. And in the last few years, you've seen more coverage, Noam Levy and Kaiser Family Foundation and other people writing amazing stories about what's going on and people who can't afford their meds, people who are being sued across the country, the toll of medical debt affecting 100 million Americans. And you see more and more attention in academic circles and journalistic circles, and then federal legislation, federal regulation, state legislation. You've seen in red states, almost especially, but in blue states as well, you've seen a lot of legislation around medical debt collection and making it at least more humane and less punitive. so there has been a movement afoot, but it never quite, like I guess we still haven't had that true reckoning. And I think part of the problem is that a lot of it is still kind of hidden in the shadows. Debt is a source of shame. People are made to feel that their debt is their fault. But if that's true anywhere, which some people argue that it isn't, it certainly isn't true in medicine, where you can't be blamed for bills incurred in the course of getting sick, which is a feature of every life.
Yeah. Yeah. I mean, that the deserving poor is a big factor in how we think of American culture and approach to money and to medicine, right? Of this idea, well, why do you have diabetes? Right? Like, like, are you buying soda with your food stamps? Like, we're very judgy around our poor in the United States in a way. I mean, maybe it's true with many, many countries, but it's American sense that you should be able to pull yourself up by the bootstraps. You should be able to do better.
Yeah.
And, I think that really gets very involved in when we think of, how we're trying to make healthcare more affordable. A great question when I was on a different debate, I brought up this topic of, I'm writing this book. I want to make healthcare more affordable. The question was, affordable for whom? Which is such a factor of how we think of the American medical system, because so many people pay for healthcare. And so the patient ultimately is almost like the bottom of that list, right? Is it affordable for, Health and Human Services? Is it affordable for the states? Is it affordable for the employers? Is it affordable for the health insurance companies? Who are we talking about when we talk about affordability?
Yeah.
The actual patient is almost not even part of that conversation often, right?
Yeah, no, totally. I mean, I think this was brought home to me more than anything by someone who wasn't medically trained at all. Jared Walker is the head of $4. I'm on the board of the organization now. It's a nonprofit that helps people apply for financial assistance. Every nonprofit hospital in the country, in order to maintain their tax exemption, has to follow certain IRS regulations, and one of them is to have a financial assistance policy. So it states usually the level at which you'll receive some discounted and free care. Every nonprofit hospital is supposed to have this. Some try to hide it and not really tell people about it. There've been some weird exposés about like hiring McKinsey to not tell people about the financial assistance policies that hospitals have, but they're out there. But applying for them is actually quite challenging. And so people like Jared started this group in order to help people get the financial assistance that they were entitled to, and get through the hurdles and the bureaucracy and the paperwork that comes with it. And so his work has been really eye-opening for me, not only in showing how difficult it is to get access to care that we say everyone should have access to, but showing like how forgotten this part of the system was. Like it's basically the last shred of hope that a lot of people have for staying out of mountains of debt. And no one was helping them do it until Jared, who was a former bartender and trampoline park operator, said like, oh, my own family is dealing with medical debt. All these people are dealing with medical debt. No one seems to know about this part of the system that, has been, is basically a lifeline for patients. I'm going to help them do it. And so and he's built this army of people who are interested in helping and getting people into the financial assistance that they're entitled to. And if you're interested in it, check out $4. But it took someone like him to do this. And the fact that it wasn't us, it wasn't the doctors, it wasn't the nurses, it certainly wasn't like the health insurance companies, it wasn't the hospitals. Like that's a source of shame for us. And so he's really put on notice.
Well, and I mean, that's a big piece of that shame around poverty that we're really facing now too, with job requirements coming from Medicaid, which is essentially just the idea that we're going to annoy our most poor and vulnerable through paperwork to the point where that they don't apply or they cannot apply, right? And I think that goes into that charity care application as well, this idea of like, well, because these people are poor or they're suffering, they're going to feel like they deserve to do this amount of paperwork. Is that a piece of that emotional component, right? And that this paperwork is a way of, absolution, of showing that you earn your benefit that you receive. I mean, it's just all very, very strange, right? In terms of the emotional component that goes into that.
Yeah, there's two competing strains, and
Yeah.
and they're not like mathematical concepts, right? These
Yeah.
aren't economic concepts, the deserving poor, the undeserving poor. This is a strain of like Christian thinking that goes
Mm,
back a long time, notions of guilt and shame and sin
mhm,
and redemption, that like are deep in our psyches and deep in our
mhm,
histories, but don't necessarily carry any scientific weight to them. I mean,
mhm,
every study that's been done of the the weight of debt or the costs of making people pay at the point of care have shown that it's really detrimental to health outcomes and often
mhm,
doesn't raise that much money at all. I mean, the
mhm,
studies, I mean, the guy who runs the FDA now under Trump is
mm,
the guy who like published a paper in a medical journal showing that hospitals that sue medical Marty Makary is his name. He's a pancreatic surgeon at Johns
mhm.
Hopkins before he became the head of the FDA. He was showing that the hospitals that sued patients in Virginia in 2017, they didn't make any money off the practice. They made 0.1% of their revenue off of the
Mm,
practice. So it would be completely unnecessary for maintaining their bottom lines,
mhm.
right? Like this question always comes up, like we got to keep these hospitals afloat. Like someone's
Yeah,
got to pay. Well, this particular way of doing it, like pursuing patients aggressively
yeah,
to in the courts, that doesn't have anything to do with keeping hospitals open.
yeah.
And so it's a solution that's we know it's not a solution.
Which in your book you talk about. I mean, so they say, why do you do it?
Yeah.
And it's that, you need to hold the line, kind of is the idea, right? Like you need to say that these debts have to be repaid and that there has to be consequences of non-repayment. I mean, it's really an emotional conversation. You're trying to maintain this hard line with people, right?
Yeah.
And that's a piece of it, do you think?
Yeah, I still don't know
Mhm.
exactly why every hospital or so many hospitals do this. I mean, I think
Yeah.
some hospitals have said, we just want to keep poor people from showing up in droves, which
Yeah.
is you know, uh, its own morally fraught statement.
Yes.
Some of them
Mhm.
say like, oh, there are federal regulations that state we have to collect at a certain level of aggressiveness, which the federal government itself has said that's not true.
Yeah.
And some, just have gotten bought into the line that we should be farming these debts out to third-party debt collectors and debt buyers and let them have at it as they will, and we can collect, maybe a little bit more money, maybe a couple of tens of thousands more dollars a year, really pittance
Mhm.
and
Mhm.
in the process kind of leave our patients in the lurch. And so there's all sorts of reasons why hospitals do it. A lot of it has
Mhm.
to do, I think, with kind of the inertia of historical
Mhm.
movement rather than any sort of deliberate attempt to do anything. Uh,
Mhm.
but yeah, I think your point about the deserving and undeserving poor is a super crucial one. But
Mhm.
also, like, it runs up against this other idea in our own history and our own psyches that we recognizing our own mortality, recognizing our shared humanity,
Mhm.
recognizing that sickness and death comes for us all.
Mhm.
And once you have that realization, then the idea of making people pay and putting people in debt for the cost they incur
Mhm.
for falling sick becomes a lot more fraught. Like, these things that we all are subject to. We
Mhm.
don't ask people to pay every time the firefighter shows up at their door. There's still public education because we know people need to get an education. Like,
Yeah.
there's still certain things that we know that we as a society want to do together.
Yeah.
And just to a certain extent, we want to do healthcare together, right? Like if you're over 65, if you're
Yeah.
disabled, if you're poor enough, but we haven't made the decision yet together that, like, no, you know what, like, enough with all these ifs.
Yeah. Yeah. So we're coming up on the last few minutes here of our time together. I'm curious how the process of writing this book and this research changed personally how you interact with the healthcare system, both as a physician, as a patient. What have you changed in the way that you move through healthcare?
Hmm. I guess more wariness,
Mm,
like, before this stuff befalls you, it's good to know what your options are, so
mm,
making sure you're in network and
mm,
making sure you you know know what the financial assistance policies of the hospitals around you are. I think, but making people personally responsible and personally liable for this sorts of very specialized
mhm,
knowledge is just way too much. So I think that we as physicians and we as, healthcare workers have a responsibility to make sure that like our places of employment, our places of work, and for many people, for many doctors who used to be independent practitioners, we're no longer that. Like 3/4 of us work for large corporate entities now. And so, making sure that our places of employment do right by patients is also a huge part of the equation. So I've been working with other physician groups and other patient groups to make sure that, more hospitals are doing right by patients. But I'm realizing that it's really not just hospitals. I think the book focuses a lot on nonprofit hospitals because those are the kind of providers we expect the most of. But I'm working on some research right now that shows that, physician groups themselves, like independent physician groups, imaging companies, EMS companies, like all these other sorts of medical providers are involved as well in putting people in debt and seeking payments in court. And so, there's a huge panoply of actors out there that we really have to work on, and not even just hospitals.
Yeah, it is all of us. I really appreciated that part of your book, not talking about there's a term that you use in like not making it a hospital-centric pathology. This is our entire healthcare system, every element of it. There are very few people who are truly outside of the system, right?
Yeah.
And outside of the financial levers and the RVUs and the CPTs and the RCM and all these acronyms that we use. I mean, it's all of us, right? We all need to be thinking a little bit differently about this.
Yeah. No, that's actually Elizabeth Warren when she was a law professor, and Melissa Jacoby, another law professor who wrote amazingly about medical debt about 20 years ago in a series of papers. They called it the hospital misbehavior model. And their point was that if you just focus on like individual actions by hospitals, like, you wag your fingers, like you guys are being bad, and not look at the larger system, right? How are we funding hospitals? What are we requiring them to do? How do they fit into the panoply of health insurance companies and other actors, private equity companies, other actors that are making a buck off healthcare? Like, then you're really going to get an incomplete solution. And so looking at this from like what's called often a political economy lens, and understanding kind of where the money comes from, where the money flows, how these different actors, stand to profit off of different arrangements. That's all really important. Otherwise, you just end up like pointing the finger of blame at some individual who may or may not be at all responsible for what's going on.
Yeah, we love a villain. A villain would be so convenient, right? It would be so great. It'd be like, great, we just get rid of United Healthcare and we fixed it. And it's more complicated than that, unfortunately.
Yeah. I mean, a lot of these actors I have very little sympathy for, and I don't think they have a role in our healthcare system. But at the same time, just spending all your time focused on one specific villain in this process is not going to get you where you want to go. Yeah.
I do want to bring up one positive story just to leave everybody with a sense of hope. And I really love the story you wrote about in the book of the two patient access billing department people who got together, and they, instead of waiting for people to apply for charity care, they screened people, they saw who was going to qualify as they came in, and just kind of created a great system. So tell us that story, so we leave with a sense of hope.
Yeah, there are solutions, right? Like maybe not solutions to everything, but solutions that help patients in concrete ways. This is Oregon Health and Sciences University, a huge academic medical center in Portland, Oregon. About 10 years ago, they decided, we have a lot of patients who aren't getting our financial assistance, even though we offer it. And so instead of having them jump through all these hoops and download these forms and print them and fax them back to us and call us back and make sure that we got them and that we're processing them, which is like an insane task to ask someone after they leave the hospital. We're just going to help them do it. And so instead of, asking them to go through all these proactive steps, we're just going to say, we can screen you at the point of care and say whether you're likely to qualify based on your income, which is so easy to find out. I mean, if consumer data has told us anything, it's that everyone knows everything about us. Instead of using it to prey on us and set us credit card applications, like, how about just telling us we don't have to pay for this hospitalization? And that's what they did. They ended up using this screening program to tell patients that they don't have to pay. And now these sorts of programs are becoming more common in certain places. And Oregon even passed a state law last year to make it required that hospitals screen patients at the point of care to see if they qualify for financial assistance. And that's like ultimately one of the big solutions I think we can come away with. Like the more states that do this, the more hospitals that do this, the more we can take this off of patients' backs. the better off we're going to be. So
Yeah.
that was a great story. I think it's like an example of what people who in the system who care about patients can do and have done.
Mm-hmm. And what a different relationship with that patient, right? When they get the letter and they say, this has been paid off. You're okay. We can go
We're
forward.
on your side, right?
Yeah.
Like we're in this together. That's
Yeah.
what we should be looking for. Yeah.
We're in it together. Well, highly recommend your book to everybody. It's like I said, a relatively quick read, a beach read in the healthcare economics landscape. It's a great one. Tell us what else you're reading or investigating, or what's piquing your curiosity right now.
Yeah, I mean, academically, I'm looking at like the history of for-profit hospitals. I'm interested in like how they came to be. Like the Hospital Corporation of America, HCA, other for-profit hospitals, which really like built their model like explicitly based on fast food companies.
Okay.
And how that idea of like fast food for healthcare affects us today. I'm also interested in kind of, I'm still looking at debt litigations or debt against patients, debt collection lawsuits against patients, and the other kind of actors that are filing those, especially like physician groups and medical imaging companies. And then, outside of academics, I'm interested in all sorts of stuff, but I'm reading this great book by Danielle Carter about, he was the editor of Vanity Fair for 20, 30 years. And kind of the book is about how the magazine industry was it's called When the Going Was Good. And it's talking about how when magazines were a big thing, like people might not remember this, but magazines were like huge in the 90s and 2000s. He's talking about how they used to fly the Concorde and take, get the most posh, expensive hotel rooms and just be the belle of the ball at every cultural event. And just reminds you that like nothing's forever. And there was a time when like certain forms of cultural production were really valued, and there's something to miss in that. Even if his particular niche of it was like extremely well funded.
Yeah, things change all the time is a great lesson from history, right? That things always feel like they've always been this way, they'll never change, and it's not true. So once again, everybody should read your book. I hope that you continue to be out there talking about this. I think it's such an important place to be focusing, and to everybody who works in the healthcare system in any capacity, just to be honest with ourselves about what's happening and what our role might be in it is a huge step forward. We can all have a conversation about the role that money plays in medicine. It doesn't have to be soul crushing, right? It can be something that you do feel shame about, or that also energizes you to think about what's possible and maybe what we can change. And so very grateful to you for writing this book. Highly recommend it to everybody. And I cannot wait to read your new one about the hospitals, the for-profit hospitals. So thank you so much for being with us this morning. You've kicked my week off in a very strong way. Everyone can go to your website here. Is there anywhere else would you like to endorse how people should tune in to you? Follow you on social?
I'm on Blue Sky a little bit, I guess. I try not to be on social media too much these days. But you can find my book at any bookseller, and I'm always happy to talk with anyone who's interested in this work and figure out ways together that we can work together.
Great, thank you so much, and we will be back with another conversation in the future. All right, bye-bye.
Thank you.